This is an important topic for all undergraduate students because once you become a doctor, you need to know about gait. Although the topic is about abnormal gait, we need to know some basic things about normal gait first. So I'll be talking about the normal gait cycle, followed by the different types of pathological gait, and finally about gait with aids. So what is gait? Gait is, if you say simply, it is the way one walks, way of walking, manner of walking, right? But if you look at the scientific definition, it is the rhythmic, repeated, sequential movements of the lower limbs. So basically, the lower limbs are helping you to ambulate when you're walking, right? And the upper limbs are getting carried on along with the, the way the lower limb is moving, and the momentum is created, and the arms are also swinging. So repeatedly, there's a rhythmic and sequential movements of the lower limb, which advances the body along a desired line of progression. So you already know that you have to go to such and such place. Maybe subconsciously, the brain knows, okay, you're walking, that you have to reach a desired destination, and you're walking even without actually making efforts. So the another important component of gait, which is that we have to, while walking, maintain a stable weight bearing posture so that the body, it's not falling here and there, right? The center of gravity of the body is within the base. And a very important component of the gait is optimally conserving physiological energy. So we often forget this because in normal gait, we are not expending extra energy, but the moment the gait becomes abnormal, then extra energy is required for ambulation. So we'll talk about this Okay, so let's start with the gait cycle. The gait cycle uh, starts with the heel strike. So once you say that the beginning of the gait cycle, so the heel is touching the floor, and then as the body advances forward, then the foot becomes flat, and the tibia has moved forward over the ankle. So after the foot flat, then it becomes mid stance. Mid stance is also known as single limb stance. So this is the point where the entire body weight is borne on one limb, and the other limb is now in the swing phase. So it is off the floor, off the ground. So this is the only time where the entire body weight is on one limb. Otherwise, during the rest of the stance phase, the heel or the foot is touching the ground. And after the mid stance, then the body moves forwards, then the heel gets off, and after the heel off, then the toe gets off. So then begins the swing phase for this particular limb, and the swing phase contains of the initial, the mid swing, and the terminal swing, and then again the heel of the same limb strikes the ground. So the gait cycle is considered when the heel strike of one limb and the heel strike of the same limb is touching the ground. So this is known as one gait cycle. It is also known as one stride, right? And one stride is made of two steps. So when this heel is touching the ground, and when the next the opposite heel is touching the ground, that is one step. So these terminologies have been modified over the times, because sometimes you may not have a heel strike. If there's a patient who's got an equinus deformity, heel will never strike, or a patient with an amputation and using artificial limb may have a different gait. So instead of heel strike, we call whatever is touching the floor is known as the initial contact. And then when the foot is going flat and tibia is coming over the foot, that is the loading response. So the whole body weight gets loaded onto the ankle and foot. And the mid stance is the same as the mid stance. And then the heel off and toe off is known as the terminal stance. So these are the other terminologies that one should be aware of in a gait cycle. So the gait cycle, as I talked about, starting with the heel strike, the stance phase, and the mid stance is the only time when the entire body weight is on one limb. So mid stance or single limb stance is only 40% of the stance, all right, of the gait cycle. So the gait cycle has got stance phase 60% and swing phase 40%, and the single limb stance is 40%, and there's the initial double stance where both the heels are touching the ground, and there's the terminal double stance where again both the heels are touching the ground. So to analyze the gait, there are various methods. of course, we in clinical practice, we are observing a patient to walk at least for 15 feet so that we can examine the gait and the abnormalities. This is known as observational gait analysis. However, gait labs are there to really accurately analyze the gait. So for doing that, we need to see the movements which are taking place at the various joints. These movements are known as kinematics. So the hip is moving in flexion, or the knee is going to flexion, the ankle rocker is going into movements. So these can be captured by cameras and sensors and photokinograms and electrogoniometers to know the exact range of movement. So these complex kinematics and the kinetics of the forces which are generated during the gait cycle. That means the internal forces can be, the muscles can be identified by the electromyography, or the actual how much force is being generated during the gait cycle when the patient is standing on a forced platform, that can be measured. So these complex kinematics and kinetics can be reproduced, or they can be assessed properly by gait lab. Of course, gait labs are very expensive because you need all these different parameters to be measured. But what we do in day-to-day clinical practice is what we're going to talk about in this lecture. So the goal of the gait analysis is basically to gear towards the treatment. So obviously, when you are doing a gait analysis, we know also more about the patient. So once you know about the patient, you can examine the patient, and you can identify what the problems are, and then we can know what deviation of gait is occurring. So the problem identification should be done at the critical events of the various parts of the gait cycle, like during the heel strike or mid stance or the swing phase, and the deviations can be noted. So the causes of the different types of abnormal or pathological gait needs to be identified, and they could be identified based on whether there is a problem with the muscle or the motor control. So the muscles may be paralyzed, for example, peripheral nerve injury. For example, common peroneal nerve injury could give rise to what is known as a high stepping gait. We'll see a video later. Or a central problem in the cerebellum could give rise to a cerebellar ataxia, right? A parkinsonism could give rise to a Festinant type of gait. And abnormal joint movements, for example, if there is excessive movements, there is a flail joint, that means there is no power across the muscles of the crossing the joint, like in post-polyorecital paralysis. Or if there is a limited joint movement like contractures or arthritis, all these can give rise to different types of abnormal gaits. And sometimes just sensations. So when we are walking, the proprioception, the feedback that we're getting back from the feet, okay, if there is a proprioceptive deficit, then that also could give rise to impaired sensation and abnormal gait. Perceptual deficits, even like a person who's under the influence of alcohol would be, having a abnormal type of gait. And of course, one of the main components of abnormal gait could be pain itself. So we'll talk about antalgic gait later. So a clinical examination is very important to really understand what type of abnormal gait is the patient is having. Now we'll talk about different types of pathological gait, and to understand this gait, because the three main types of pathological gait in case of a hip joint pathology are the Trendelenburg gait, the Antalgic gait, the short limb gait, and there could be other types of gait like stiff hip gait, extensor gait. I'm not talking about that. As an undergraduate student, if you should understand these three gait, then that will really help you understand the biomechanics and the patient's pathology. So the biomechanics is that hip is a class 1 or first class lever. So you all know from your physics that there are different types of lever, and the first class lever is where the fulcrum is in the middle, and like a seesaw, the load on one side and this lever arm has to balance the load on the other side and the lever arm, then only the seesaw will be balanced. So a heavy person sitting on one side can, or on the other way, a lighter person sitting on one side can balance a heavy person if the lever arm is more, because this product has to balance this other side product. So in the hip joint also, when a patient is standing on one limb, so there is a hip joint which is the fulcrum, and the weight of the body, okay, so that's the body weight, okay, that and the body weight lever arm has to get balanced by the abductor forces which are being generated and the abductor lever arm. So as I talked about a single limb stance or mid stance where the entire body weight is on a single limb, so that is known as single limb stance. Whereas compare it to when we are standing, when we are not walking, when the body weight is on both the feet, then the body weight gets distributed equally onto both the hips, right? The center of gravity, which is in front of the S2 vertebral body, falls in between the base, so body becomes stable. Whereas when there is a single limb stance or a mid stance, where the entire body is on one single limb, then what is happening? You see, the body weight is now eccentric because now it is the weight of the head, the trunk, the upper limbs, and the weight of the opposite lower limb, which is in the air in the swing phase. That is all that weight has to be balanced by this abductor muscles here. The force is created by this. So the body weight lever arm becomes much more compared to both the feet on the ground. So on a single limb stance, so this entire body weight has to get balanced by the abductor forces. So if you understand this very simple biomechanics, then you'll understand that, you know, to balance this body weight and the body weight lever arm uh, and create a force by the abductor muscles, hip abductor muscles, so that the pelvis does not fall down when the patient is standing on one side. So to do that, this product can only be decreased because the body weight cannot be decreased, only be decreased if this lever arm, body weight lever arm becomes less. So this product of body weight and into the body weight lever arm will be less if this lever arm gets decreased. That means the center of gravity gets shifted towards this side. That means the person lurches towards this side. So the moment a person lurches on this side, then this body weight lever arm becomes less. So the abductors need to have less forces to balance this. And if you look at the biomechanics in the other way, as I mentioned, that the center of gravity, when on standing on both feet, is in the middle between the two, that is within the base. But on standing on one limb, the center of gravity is outside the base. So it can only come within the base when the person lurches on this side. Then the center of gravity will be over this one limb foot, right? Whereas if the person lurches on the opposite side, then the center of gravity is going away and the body weight lever arm is also increasing. So that is not at all biomechanically stable or energy consuming, right? So always in every pathological condition during the stance phase, the lurch is always on the side where the patient is standing on the stance phase, mid stance. Lurch can never be on the opposite side on the during the stance phase. So this is a very important fundamental aspect of gait that everybody should understand. If you understand this, then Trendelenburg gait becomes very easy to understand. So to understand Trendelenburg gait, this is a video which shows a person standing. Just a minute, if I can shut off the. So if he's standing on the normal side, and when he's standing on the normal side, the pelvis is not dropping, right? So that means the body weight, that means the weight of the head, the trunk, the upper limbs, and the weight of this limb is getting balanced very nicely by the abductor muscles here, gluteus medius minimus, and the pelvis is not dropping. Now, the moment I ask him to stand on the affected side, he has got a tuberculosis of the hip joint, tubercular arthritis, and when he stands on this side, watch what happens. So we have asked him to stand on this side and he will do something known as a trick movement. So he is taking a support. So when he's taking a support, the ground reaction force is there. Now when we remove the support, he is lurching on the side where the affected side. So when he lurches, Watch the video again. When he lurches, the center of gravity comes towards this side and the body weight lever arm decreases. Now, this is a trick movement which he's doing. So if you watch this trick movement, what is he doing? He is like getting a support on the opposite side, right? On the side he's standing, because the body weight lever arm has to be balanced by this, right? So he has to lurch this side, but if he wants to prevent this lurching, he takes this support, and this is equal to like walking with a stick or a cane on the opposite hand. So when he's taking this support, he is pushing his hand downwards, and a ground reaction force equal and opposite is being created, which creates a turning moment, and that sort of uh, deviates the force and decreases this force, so that he is able to stand without lurching. But if you ask him not to use this support, then he will lurch on this side, and this is known as a Trendelenburg test positive, Trendelenburg sign. And the equivalent of the Trendelenburg sign is the Trendelenburg gait. So once more the video, normal side, pelvis is not sagging. Abnormal side, to prevent the pelvis sagging, he takes support or he lurches on the affected limb. So this is the Trendelenburg sign. And again, as I mentioned, that because when he's standing on this limb, and if he has to balance by this abductor here, that means the body weight lever arm into this body weight into this body weight lever arm has to be balanced by the abductor forces and the abductor lever arm. So to decrease this product, he shifts on this side his center of gravity, so the body weight lever arm becomes less, and he's able to balance himself. So the same patient, when we asked him to walk, so this is known as the Trendelenburg gait, and this sway of the trunk is known as lurch, right? So later we'll talk about lurch and list. So lurch means when the trunk is swaying, and as I mentioned, it's always swaying on the side where the patient is putting weight during the stance period. And this is a child who had a dysplasia of bilateral hips. We made him walk. So you can see this is bilateral Trendelenburg gait. This is known as a waddling gait, like a duck waddles on both sides. So this child has got a bilateral hip pathology and is waddling on both sides, bilateral Trendelenburg gait. Now we'll come to Antalgic gait, and the Antalgic gait, again, if you have understood the biomechanics, so during the mid stance phase, when the patient is standing on one limb, obviously all the load is being generated onto that limb. So because the hip joint is painful, he is not able to stand too much on that one single limb when the other limb is off the ground in the single limb stance or the mid phase stance. So that part of the gait cycle is less. It is like equal to, suppose you are walking and there is a pebble which comes into your shoe. So when you want to walk and on that limb where the pebble is in the shoe is on the ground, you will quickly take the foot off the ground because putting weight on it is going to be causing pain. So similarly, so the mid stance phase becomes short, right? And the opposite side limb in the swing phase will take a shorter step, because if he on the opposite side, if he takes a longer step, that means on the side which is on the mid stance, we'll have to bear the body weight for a much longer period, so it will be more painful. So the opposite side step is much shorter. And the lurch, I said, and if you understood the biomechanics, lurch always will be on the same side. By lurching on the same side, the body weight lever arm is decreased, so the abductor forces which are required to balance will be less. The abductor forces are less, the pain in the hip will be less. So let's see this example of this patient who had tubercular arthritis. So it's a painful hip here. So you can watch that the stance phase has started, but the mid stance where this limb is off the ground is very, very less, because that is the time when the entire body weight is on the ground. So he's hesitating before doing a mid stance where the opposite limb will go into the swing phase, and the opposite side, the stride length, step length will be less. And if you look from the back again, so the affected side, this mid stance is less, and the step length on both sides could be less, because here, because of the arthritis, limited motion, so this side also could be less because it could be painful taking an increased step here, and the opposite side also could be less. So that's why the step is shorter. And lurch, as I said, is on the same side as the affected hip pathology. So this is about the antalgic gait: short mid stance, decreased stride length on the opposite side, and lurch on the same side. These are the three important characteristics of the antalgic gait. Again repeating, short mid stance, right? The mid stance phase or a single limb stance where the entire body weight is on the single limb is short in antalgic gait. In the short limb gait, there is no pain. It's just that the limb length discrepancy is there. So one limb is shorter than the other. So what happens when he's walking on the side which is shorter, right? There is no lurch because the abductor muscles or the fulcrum or the the power is not affected. It is just the limb length discrepancy. So there is no lurch. It's just the shoulder will go vertically down. And we can watch the same patient with the shoe raise. So here is a patient who's got a tuberculosis of the hip joint, and he's got a Trendelenburg gait as well as a short limb gait. So you may have a combination of gait because of different biomechanics. You can have an antalgic with a short limb with a Trendelenburg all combined also. So if you see this person's, the gait is little short limb, shortness is there. So there's a vertical dip of the shoulder when he's putting his stance phase on that side. Now, if we asked him to wear a shoe on that side, you can see that after wearing the shoe, the vertical dip is less, but the lurch has increased because the Trendelenburg component gets unmasked by compensating the limb length discrepancy. So that is a very important factor to be considered by during treatment, that if there is a shortening of limb and there is a Trendelenburg component, so one must not compensate the shortening entirely. One must leave a little bit. Suppose it's 5 centimeter shortening, should have compensation so that shoe raise of only 4 centimeter or limb lengthening of only 4 centimeter. Leave 1 centimeter behind, because if you compensate fully, then the Trendelenburg component gets more exaggerated. And this is a child with a proximal focal femoral deficiency. That means the proximal part of the femur has not developed. That means the head of the femur, head, neck, and the trochanteric area. So there's a 25 centimeter shortening in this side. So you can imagine that how much is the vertical dipping of the shoulder. I think this video probably is not working. So during the stance phase, there's a complete vertical dipping of the shoulder. Now there is other type of abnormal gait. It could be one is the common pathology seen in post-polio residual paralysis, which is known as the hand to thigh gait in quadriceps weakness. So when the quadriceps muscle is weak, what is the function of the quadriceps muscle? So right at the start of the gait cycle, I talked about the heel strike. At the time of heel strike, the knee is completely straight, extended. So to keep the knee extended, the quadriceps muscle has to act. Now, if the quadriceps is weak, this extension does not take place and the knee collapses in flexion. So to prevent this collapse, the person pushes the knee backwards. So this is known as hand to thigh or hand to knee gait. And this girl, yes, she has a hand to thigh gait. Right? So persons with the weakness of quadriceps can compensate by a hand to thigh gait. And if you comment at postgraduate level, there are other ways of compensation like external rotation, leaning forward. So I'm not talking about that at undergraduate level. So you should understand this very important abnormal gait, which fortunately after the eradication of polio has come down. And this same patient, I did a surgery of correction of the hip release and the knee release. That's all. The flexion deformity is gone, and thereby the patient is compensating by little external rotation and forward bending, and the hand to thigh support for stabilizing the knee is not required. So there are ways of compensation by creating an equine. So I'm not talking about all that detail. So for your purpose, only a hand to thigh gait is important in quadriceps weakness. Now, similarly, there is known as a pretibial muscle weakness. Pretibial muscle weakness, like for example, the common peroneal nerve paralysis. The common peroneal nerve, as you know, supplies the tibialis anterior, extensor digitorum longus, extensor hallucis longus. So these muscles are helping the foot to be kept at 90 degree to the tibia when the swing phase is taking place. So if these muscles are weak, so the foot drop occurs, and so the foot becomes actually uncontrolled, and because of the foot drop, it becomes longer, right? So the ankle does not dorsiflex and keep it in neutral position while clearing the ground during the swing phase. So to clear the ground of a longer limb, then the patient has to do ipsilateral hip or knee flexion. So this is known as a high stepping gait. Now here is a patient of post-polyarticular paralysis with a quadriceps paralysis, bilateral hand to thigh, and this side you can see there is a weakness of the pretibial muscles because of the polio, and because of that, patient is not able to lift and clear the ground. So he's pushing the thigh for the quadriceps weakness and pulling it upwards for the ground clearance. High stepping. So in reality, though we are talking about gait in a very simplified manner, but there could be combination of abnormal gait patterns as seen in this child. And once more, so this bilateral quadriceps weakness and this side pretibial muscle weakness. So instead of heel strike here, the entire foot is striking the ground. There's no heel strike, right? So this is known as a foot slap. Foot is slapping the floor. And a high stepping gait. So there are other ways of compensation also, circumduction, etc. I'm not confusing you with that. Now here is another type of abnormal gait. This is a patient got tuberculosis of the lumbar spine. You can see a kyphotic deformity, and because of the pain and spasm, there's a guarding. The patient is walking, just with a guarded sort of a posture, without any jerking, without any movement in the lumbar spine. So there's a hyperlordotic sort of gait of the lumbar spine. This is known as a Alderman gait, and Aldermen are actually not seen in India, but in the West, aldermen are city councillors. So city councillors are walking in the city, with their lordotic gait, as if they're the lord of the city. That is why this term has come, alderman gait. And you can see here that there is no lurch, there is no movement of the trunk. There is instead, because of the muscle spasm, there is a guarded gait without any movement of the lumbar spine taking place. It's very painful, is wincing also. Then circumduction gait can take place in various due to various causes. Here is one example, that this patient's knee joint is ankylosed. So the knee cannot flex during the swing phase, like the foot drop. During the swing phase, the knee needs to get flexed for the ground clearance. It cannot do, so it becomes longer. So he is circumducting, right? So there could be various causes of circumduction gait, even a pretibial muscle weakness, where the muscle, the tibialis anterior extensor digitorum longus and extensor hallucis longus cannot dorsiflex the foot, then he can clear the ground by high stepping gait or a circumduction gait. In fact, it has been seen that circumduction gait is more energy consuming, less energy consuming than a high stepping gait. So patients who want to walk faster, they use a circumduction gait. Now this is another abnormal gait, and that is the internal hip rotation gait. So this patient has got increased hip anteversion, which often happens in cerebral palsy, and so is sitting in a W position. And in a patient of internal hip anteversion walks, there's an in-toeing gait. So you can see there's in-toeing, and here's the patient with a bilateral in-toeing gait, which is known as a pigeon toe gait. Not working. So this video is probably not working. Anyway, so you can see on this side, and this side is a bilateral in-toeing. This is unilateral in-toeing. To understand this, if you see if you keep the femur bone on a table, you find that the condyles are touching the table, the trochanter and the head of the femur touches the table. It does not touch the table because of the anteversion, right? Now, if the anteversion normally at the time of birth is around 40 degrees, right? As the infant grows up, it becomes less and less, and during the adult, it becomes around 8 to 12 degrees, right? Sometimes even up to 15 degrees. So if there is an excessive anteversion, what happens? Now, if you look at this diagram, it shows that this is the limb, this is the head of the femur and the neck. So this is normal anteversion, okay, like this normal anteversion, not excessive. So the head is within the acetabulum during the normal anteversion, because the acetabulum is also anteverted, right? Now what happens is that when there is excessive anteversion of the uh, femoral neck, right? So that happens because less development in cerebral palsy. So when there's excessive anteversion, the head tries to get dislocated or subluxated away anterior to the acetabulum. Now to get this head back into the acetabulum, the person has to do internal rotation, right? If he does external rotation, it will go further away. So internal rotation, so that is the genesis of the in-toeing gait. If there is excessive anteversion, the child will rotate the thigh and the limb to get this head into the acetabulum, and that is known as a so the same slide I'm showing, that is known as the in-toeing gait. And the child, because there is internal rotation to when the child is sitting like this, both sides are increased anteversion, so both sides internal rotation, and the child sits in a W position, or both are internally rotated. The petal are facing inwards, feet are facing outwards. So after internal rotation, there could be an external rotation type of abnormality. And here is the patient who has got uh, cerebral palsy with spasticity of the extensor lateral hamstrings, right? So because of that, there is a knee flexion or a crouch gait type, as well as he's raising the arms, you can see. So a child who has got poor biomechanics, to bring stability when a child walks, he walks with a wide base gait, so the center of gravity falls within this wide, and he tries to raise the arms. So raising the arms helps in balancing. For example, if you see a tightrope walker, he uses a long rod in his hand and he balances, so that when you um, the musculature is poor, unstable, like in cerebral palsy, raising the hands sort of balances. The other way these children balance themselves while walking is by walking fast. So otherwise they are not able to stand properly. But by when you ask them to walk, they will quickly run across the room. That's uh, you know equal to, like, when you're cycling. If you cycle slowly, you tend to fall, but if you cycle fast, you balance yourself. So by running fast, they are able to balance. So these are the compensatory mechanisms in abnormal gait. So external rotation gait can also take place when there is excessive sort of the hip, like in internal increase anteversion, so increase retroversion. But equivalent to that is slip capital femoral epiphysis, and that the head slips, and so there is an external rotation type of gait. Now I was talking about the energy consumption. So it has been seen that during walking, during the normal natural gait speed, there is an optimal use of momentum, and so the least energy is used by the person when he's walking for every step, every meter he walks. Right. So if a person does not walk in his own natural gait speed, then the momentum also changes and the energy expended also increases. So if you see in a park, different people walking, they are walking at the different speed. So if you walk slower or faster, then you can actually cause more energy consumption. So when a person starts walking faster, when the speed increases, there is increase in the swing phase and decrease in the stance phase, right? So in fact, when a person is running, there is no double stance. It's known as a double float. So both the feet are never touching on during running, right? So double stance is not there. And you must also be aware of certain words, and one of them is cadence. Cadence is number of steps per minute. Number of steps per minute is not equal to the speed. It's not that one becomes faster or slower. For example, if there are two people walking, one is, let's say, the father and a small child. right? So they are walking in the same speed, but the father will be taking, because of his height, longer steps and covering the same distance with longer steps, while the number of steps per minute will be more for a child. So the cadence in a child will be more. The speed of both are the same, right? So the number of steps one usually takes is varies between 70 to 130 steps per minute, average of 90 steps per minute. This is cadence. And regarding the balance, the center of gravity, as I said, in front of the S2 vertebra, that goes up and down when the normal person is walking the gait cycle from the heel strike to the mid stance. So highest it goes in the mid stance and then comes down during the double stance. So this deviation of the center of gravity with the body going up and down is around 5 centimeter. The body tries to control it to keep it within this 5 centimeter. Right? If it becomes more than 5 centimeter, for example, if there is a knee contracture, so when during the stance phase, there is going to be a dip, right? Or in a short limb gait, there's going to be a dip. So center of gravity will come down. So then more energy expenditure will be used. Similar to the vertical shift of the center of gravity, there is a lateral shift of the center of gravity when the person walks from one limb to the other, and the pelvis and trunk shifts. And the width of the walking width of the walking base, that is the distance between the two heel, is around 5 to 10 centimeter. If it's narrower than 5 centimeter, is known as a narrow base gait. If it's wider than 10, it is a wide base gait. For example, this child of cerebral palsy, he's got a wide base gait and he's also raising his arm a little. So the center of gravity is falling between the 2 feet in a wide base gait. Contrary to this is a cerebral palsy patient who's got adductor spasm and adductor contracture, and there is a crossover. It's called a scissoring gait. So obviously the center of gravity, there is no base, so its patient is going to be very unstable. So the father of the patient is holding the child to make the child stable. So this is a narrow base gait, and in fact crossover is known as a scissoring gait. So sometimes in cerebral palsy you could have what is known as a dynamic type of gait. That means when you examine the patient on lying down, there is no crossover. The patient can abduct the limb, but make the patient walk, then the crossover starts. So during the enforcement of the muscles during walking, there is a dynamic gait. Now, different types of abnormal gait can occur in the foot also. So in the foot, we can have what is known as a spade foot. Usually the sole is never visible, but like a spade, it is visible when the tibialis anterior is either contracted or it is in spasticity, like in cerebral palsy. And if the tibialis posterior is in spasticity, like this child, there is a equinovarus. So tibialis posterior action is plantar flexion and varus, whereas tibialis anterior function is dorsiflexion and varus. So here this child, when he's walking, is a equinus, plantar flexion and varus. So I did a tibialis posterior transfer in this child, and then the gait improved. Now this is a child with an everted foot gait. So if the everters are more spastic or more powerful, or the inverters are poor or weak, then one can have a everter foot gait. So like this, we can have different types of abnormal gait, and in cerebral palsy itself, one can have a crouching gait, a bunny hop gait. So as I said, if the musculature is poor, then the patient tries to get the center of gravity closer to the floor and hops like a bunny. Scissoring gait, circumductory, hip hiking, inverted foot, and internal rotation, all types of gait can be seen in cerebral palsy. Now, I talked about lurch, which is the sudden movement of the trunk, whereas list, there is no sudden movement. It is the entire body is tilted. And I talked about this in my lecture earlier in the spine. I think for your batch, taken it in 2 sessions. So we talked about how if there is a disc prolapse and the disc prolapse is pressing on the nerve root. If it is somewhere here, that means at the axilla. So to get this pressure off, the patient will be shifting on the same side. Whereas if the the nerve root is going here, and this disc is coming from far lateral. That means the shoulder impingement. So it goes on the opposite side to prevent the nerve root irritation. And in a lumbar canal stenosis, patient sort of has a stance forwards known as Timian stance. So these are different other types of abnormalities in the gait. I talked about the biomechanics, and there itself I gave that example of how that boy was doing a trick movement of pushing down. The same thing is the use of a cane. So when a person is using a cane, he's actually, what is happening, he's pushing his body weight on the cane, and the ground reaction force equal and opposite by the Newton's first law of motion. It sort of creates a turning moment of force, and this whole lever arm gets turned on that side by this force equal and opposite which is created, and that helps to generate like the seesaw. Somebody is giving a push from this side. So it has been seen that the force transmitted from the cane decreases the body weight effectively and relieves the hip pressure. And Powell's did a calculation that if a 9-kilogram weight is put on the stick which is held on the opposite hand, then 40% load reduction takes place. So there is no point of holding the stick on the same side of the hip pathology, because if you're doing this, then it is not helping this turning moment of the force. And in fact, by holding it in the opposite hand, the additional also advantage is that the center of gravity is now falling between the walking stick and this foot, whereas if it is held in the same hand, then the space is less, so center of gravity cannot fall in this space, right? So this is using cane. Similarly, using crutches, there are different type of crutch gaits, which I'm not going to details for your undergraduate level, but you should know what is a swing through crutch gait. That means the patient swings through, and a swing to, that means patient walks till the crutches. So these are axillary crutches. So the axillary crutches, the crutches should not be touching the axilla, right? Because then you can have a high radial nerve palsy. So the triceps muscle needs to be very strong to control a person having this crutch gait. And one should always obviously avoid such a ungainly and demeaning to the humanity, a crawling type of gait. One should always try to give dignity to a person by doing all the best to making this person upright and have a bipedal gait, not a quadruped gait, right? So human beings are bipedal, and the only other in the animal kingdom with bipedal gait are birds, right? Human being and birds are the only two who have bipedal gait. Rest all usually they have a quadrupedal gait. Now I've talked about the normal gait cycle. I've talked about especially the biomechanics to understand the Trendelenburg gait and lurch and Antalgic gait and the different types of pathological gait. So we have 3 minutes left. If there are any questions, it will be very good to answer them. Yes, any questions? Please feel free to ask any questions. Anything which was not clear, I can repeat that. Any question on the chat box? No questions? Dr. Yasim, are you connected to the online lecture? Dr. Yasim, are you connected? So there is one question. Let me just go up. Can you explain list again? Okay. In limb, trunk is deviated to normal side and to thigh gait. And Antalgic lurches on the same side. Okay, okay. Good. Interesting questions. Okay. Okay, so list is basically the difference between list and lurch is in lurch there is a sway of the trunk. Okay, there is as if the trunk is swaying like a tree is swaying during a storm. So the best example of sway is when if you know the game of fencing, when one opponent lurches towards the opposite side with the sword, right? So that lurch, the sharp bend of the trunk, that is known as lurch. Whereas list, there is no sharp bend. Because of pain and spasm, the patient adopts a position which is always tilted, like a ship is tilted on one side, right? So it is always tilted. So that is known as a uh, uh, list, right? So that is one difference. And regarding the question of the antalgic gait, so it is not that the pressure will be more. It appears as if the pressure may be more, right? But what happens is because the body weight lever arm is less, so the if you look at the seesaw again, the biomechanics, so the product of the body weight lever arm and the body weight is less, so automatically the forces the patient has to uh, have on the abductor muscles to balance this will be less. So the forces will be less, the pain will be less, right? And of course, because of the antalgic gait, there would be less stance, mid stance phase, right? But the lurch will be on the same side. It's the question of the lurch, right? And regarding the question about the Alderman gait, it is Alderman gait is again it's like a list. It is patient is not the trunk is not deviating sharply. It is maintained by the muscle spasm. So this is in tuberculosis of the lumbar spine. It's very characteristic in lumbar spine tuberculosis. The muscles of the lumbar spine are keeping it in spasm and having a guarded gait. Let me see if any other questions. Stick length. Okay, stick length, always whenever we measure a stick length, okay, or the length of crutches, we have to make sure that the stick should be held in such a way that there is a flexion of 30 degrees at the elbow, right? And the stick should be, when you are keeping the elbow at 30 degree, the stick should be 6 inch in front and lateral to the lateral toe, the tip of the lateral toe. So that is where the stick should be, and with the elbow in 30 degree, that length should be the ideal stick length, right? Similarly for the crutches, one should measure it about 1 inch or 2.5 centimeter distal to the axilla with the elbow at 30 degree, and then with the end of the crutch 6 inches in front and lateral to the tip of the last toe. So that should be the ideal length of the stick or crutch. So thank you for the good questions. So somebody wanted to know the gait cycle again, how less length. Less length of the limb increases. I didn't understand the question. Less length of limb increases the less length of the limb. I don't know. You are probably misunderstood. But anyway, somebody wanted to know the gait cycle. So let me go back to the gait cycle once more. That's important part. So the gait cycle starts from the heel strike. So heel strike means the stance phase has started, right? Then after the heel is on the floor, then the body is moving forwards, then the foot will strike, right? So the foot will strike and the tibia has moved forward, body has moved forward, right? So at this point, at the heel strike, the tibia is at 90 degree to the foot. So dorsiflexors are working, ankle dorsiflexors. Now The tibia is actually moved forward. So it is, here it was 90 degree, but here it is less than 90 degree. Right? In fact, 3 degrees of less. So there's the effective dorsiflexion of the foot. And then there is a mid stance where the entire body weight is on single limb stance. And after the mid stance, then the heel off and then the toe off. So that ends the stance phase, and then the swing phase starts, initial, mid, and terminal, and again the heel strike. So this is one gait cycle, right? And different other words are initial contact instead of heel strike, and then you have loading response where the body weight is getting loaded, and then the mid stance is the same, and the heel off and toe off is the terminal stance. So if there are no other questions, then I think, any other questions before I close? So I don't think there is any other question. So thank you so much, and I hope I've not gone extra, 5 minutes extra I've gone, sorry. So we now end this lecture. Thank you so much.